Good evening, everyone. After a day filled with enlightening and impactful sessions, now we move on to the next exciting session, that is the most important session for the today, that is the orations. The session not only celebrates the outstanding contributions of distinguished individuals, but also inspires us to strive for the excellence in our own endeavors. We are privileged today to feature two remarkable orations, the Delia Horton Oration and the A.S. Kanakasabhavati Oration. Let us begin with the Delia Horton Oration, which has been awarded to the esteemed Professor Nikhil Tandon. So for this, we'll request the chairpersons to provide us with the insights into the life and legacy of Delia Horton. I am delighted to invite Dr. Vinita Ravindran, the Dean of our Nursing College, to the stage. May I invite also Professor A.K. Asad Khan to join the chairpersons on the stage.
Good evening, everyone. It is indeed an honor to speak about the remarkable contributions of Miss Delia M. Horton at this time. Miss Delia Horton was a pioneer in the establishment and development of nursing education at Christian Medical College, Vellore. Joining Dr. Ida Sophia Scudder, the founder of the Christian Medical College, in 1909, she became the institution's first registered nurse and the nursing superintendent, playing a pivotal role in initiating formal nursing training programs in India. Under Ms. Horton's leadership, the nursing school at CMC was established in 1909 with the first batch of 5 students. This program evolved over time, becoming a structured diploma nursing program in 1932 and later offering India's first Bachelor of Science in Nursing degree in 1946. Ms. Horton's dedication to nursing education laid a strong foundation for the professionalization of nursing in India. Ms. Delia Horton dedicated her life to advancing healthcare delivery and nurturing a culture of excellence in patient care and compassionate work. Through her leadership, mentorship, and hands-on efforts, she brought a unique blend of professionalism and humanity to her work. Her vision was clear that health care must not only address patients' physical ailments, but also honor their dignity, emotions, and individuality. Ms. Horton's contributions extended beyond education. She was instrumental in organizing nursing services at CMC, thereby ensuring high standards of patient care. Her commitment to integrating nursing education with practical clinical experience set a precedent for future nursing programs across the country. Ms. Horton's collaboration with other pioneers such as Ms. Veera K. Pittman was instrumental in advancing nursing education in India. Their dedication not only enhanced the quality of nursing care, but also elevated the professional status of nurses in the country. Ms. Horton, along with Dr. Scudder, worked tirelessly to overcome societal hesitations regarding women's participation in nursing. They visited schools throughout South India, persuading girls and their parents to consider nursing as a respectable and rewarding career. Their efforts significantly contributed to the upliftment of women in Indian society and the enhancement of healthcare services. Her vision and dedication have left an undeniable mark on nursing education and healthcare in India, inspiring generations of nurses to serve with compassion and professionalism. Today, the College of Nursing at CMC Vellore stands as a testament to their vision, offering a range of undergraduate, postgraduate, and doctoral programs, and serving as a WHO collaborating center for nursing and midwifery development. We are happy that she is chosen as the person on whom this oration is done. Thank you.
Thank you, Dr. Vinita, for walking us through the life and legacy of Delia Hartle. May I now invite Professor Nikhil Tandon to come on to the stage. Next, I am honored to invite Professor Asad Khatun, the Regional Chair of the International Diabetes Federation, South Asia region, the President of the Diabetic Association of Bangladesh, and the Chairman of the Board of Trustees of Bangladesh University of Health Sciences. Professor Khan will now introduce Professor Nikhil Tandon, the recipient of the Delia Hartle Oration.
It is indeed a great privilege to introduce Professor Tandon, who I believe needs no introduction, at least for this audience. But anyhow, that's the system. So I will just read it out. Dr. Tandon, an esteemed alumnus of the All India Institute of Medical Sciences and the first Indian clinician to earn a PhD from the University of Cambridge, UK, has seamlessly integrated clinical expertise with groundbreaking research. A dedicated clinician, passionate and visionary researcher, Dr. Tandon's work spans clinical, basic sciences, epidemiology, genetic predisposition studies, with a focus on non-communicable diseases. His remarkable contributions include pioneering population-based epidemiological studies, randomized control trials on clinic and system-based interventions, and research on genetic predisposition to diabetes. A trailblazer in collaborative research, Dr. Tandon's effort has consistently prioritized societal impact over individual recognition. His research has provided definitive answers to enduring questions and informed strategies for disease management at the patient, clinic, and health system levels. The task sharing with electronic decision support model developed through his collaborative group has been incorporated into operational guidelines of India's National Program for Non-Communicable Diseases. Dr. Tandon's contribution extends to numerous national and international advisory roles, including Chair of WHO Technical Advisory Group on Diabetes, TACD, member of WHO Guideline Development Group on Definition, Diagnosis and Classification of DM, and Management of Diabetes in Pregnancy, National Program for Non-Communicable Disease, Scientific Advisory Board of ICMR, Apex Committee of DBT, and Governing Council of NBEMS. Dr. Tandon has served as President of the Endocrine Society of India and the Indian Society of Bone and Mineral Research. He is a Fellow of the Indian National Science Academy, National Academy of Sciences, India, Indian Academy of Science, and the National Academy of Medical Sciences. Among his numerous accolades, Dr. Tandon has been honored with B.C. Roy Award for Eminent Medical Teacher by the Medical Council of India and the Padma Shri, India's fourth highest civilian award. With deep respect and admiration, we honor Professor Tandon with the prestigious Delia and Houghton Oration Award on this 10th day of January 2025 for his unparalleled contribution to medicine, research, and public health, which have left an enduring legacy in management of diabetes. And I dare say, I have been privileged to know him for a long time, considered as a friend of.
Thank you, Professor Khan, for that excellent introduction. As a token of our gratitude and respect, I now invite Dr. G. Matthew, the Professor of Obstetrics and Gynecology, to present the ceremonial shawls to Professor Tandon. Thank you, Dr. Gigi and Dr. Khan. Finally, it's my honor to invite Professor Tandon to deliver his oration.
I'd like to start, not merely because it's a convention, but because this is really a big honor to be nominated for delivering this oration. I'd like to thank the jury which adjudicated and came up with my name, and I hope I can live up to the expectations when they decided to choose me for the oration. It's also interesting because a large part of what I've done in the last 10 or 12 years has been how to harness non-physician healthcare providers in a more central role for care of people with non-communicable diseases. And I think it is more by serendipity, but I think it's an honor and privilege for me to be delivering an oration named after somebody who was a trailblazer in the field of nursing, not only in this institution, but perhaps in the country altogether. I'd also like to specifically thank Nihal, a very old friend. People often call him Nikhil and me Nihal, so there's this, without any evening libations, it still does happen. And thank you, Nihal, for organizing this meeting, and as usual, you and your team deserve a lot of congratulations for the meticulous way this meeting has been organized and putting together specialties which are right across the board. So what I intend to do is to speak about gestational diabetes, and I think we've heard a lot about Delia Houghton, but for the few people who may not know about the founder of the Christian Medical College in Vellore, I think it's important to point out that, again, it's interesting. Dr. Scudder was born of missionary parents, and the reason she chose medicine was as a result of events which transpired when she was visiting her parents in this part of the world. And those are the horrific events of a single night when 3 women lost their lives due to childbirth. And that's what triggered her desire to do medicine. She completed medicine. She established first a hospital for women, then a college for women, which eventually then became a college where both men and women would study. Fortunately, we've moved on a bit from those times, and with significant improvement in antenatal care, those horrific nights are perhaps a thing of the past. But unfortunately, it opens the gates for yet another set of problems, and that is the postnatal manifestations of the metabolic perturbations which arise during pregnancy and the aftermath. And I will be talking predominantly of that during the course of my talk. So the outline for this presentation will be a little bit about postpartum hyperglycemia, but largely the story would be, if I can use the word, conversion to type 2 diabetes. I know this is a controversial area, whether it's a conversion, whether it's an evolution, or it's an inevitability. We will see and listen. Whether it's type 2 diabetes or something else, we will possibly understand, but for the sake of simplicity, let's call it conversion to type 2 diabetes. We'll talk a little bit about intervention strategies for preventing conversion, because there's no point harping on something that, there is a problem, but not trying to do something about the problem. Look at the risk factors of postpartum diabetes in women with prior gestational diabetes. Because of changes in diagnostic criteria, what was the single bucket of gestational diabetes seemed to be getting bifurcated and trifurcated into other factors or other conditions also, one of which is called overt diabetes in pregnancy, and I'll try and wind it up after that. So again, this audience, and this audience really doesn't need to be told that the overall risk for diabetes amongst women who've had gestational diabetes is about 10-fold higher compared to their normal glycemic peers in pregnancy. So it's clearly either they have a predisposition which first causes the hyperglycemia in pregnancy and then later manifests, or the event during pregnancy triggers off a set of events which causes it. But nonetheless, it's nearly a 10-fold increase in future diabetes risk. Now, one of the problems with gestational diabetes is that it's been sort of, if I can use the word advisedly, plagued with a range of diagnostic criteria. It sometimes becomes very difficult to unravel whether a gestational diabetes diagnosed in one part of the world is the same as gestational diabetes diagnosed in the other part of the world. But the Carpenter and Couston criteria stayed for a very long time, and they were, of course, modified from or evolved from the prior O'Sullivan-Mahan criteria. And the Indian data was, and I'm just using 3 studies to exemplify that. And there are 2 studies prior to the ones in which we were involved in. One was done in Pune, in the western part of the country, which showed that women who were diagnosed with GDM had, in a period of a median follow-up of 5 years, about half of them had moved on to develop diabetes, which is really, really large, remembering the fact that these are young people who get gestational diabetes. Study from Mysore by Dr. Krishnaveni and her crew, a smaller study, but again giving very similar numbers. And then we performed a study which was a little bit larger than the others and showed the following, that if you actually add up, if the mean postpartum follow-up period of about 1.5 years, about a third of women had developed diabetes. And if you had a follow-up which was longer, somewhere between 2 and 4 years, again that 50% number came on. So clearly this is a very, very significant issue, that young women who are usually in their 20s, maybe their early 30s, who develop gestational diabetes, very soon go on to develop type 2 diabetes. So this was the first study which we did, which was data from, or the study was conducted between Delhi and Hyderabad. About 360 odd women were screened. The first thing you'll notice is that it's been very difficult to get women back for their post-delivery oral glucose tolerance test. It is standard clinical practice that every woman who's had gestational diabetes must come back for their GTTs. This was a research project, and therefore we had staff who was running around and trying to get it done. Despite that, just over 1 in 3 women actually underwent a GTT. That clearly means that this is an area which needs our intervention. But the second part was that if you look at a combination of pre-diabetes and diabetes, nearly 3 out of every 4 women in the follow-up period of this study had some degree of dysglycemia. That means only 1/4 of them were normal glycemic. Now that's, again, a very large number. And 1 out of 2 women, as I said, had developed diabetes after 2 to 4 years. And compared to the general population, if you looked at data from population-based studies, if the woman was between 20 and 29 years of age, they had about an 18-fold excess risk for developing diabetes. And 30 to 39 years, it was about 10-fold. So a very, very important thing. So what we really found was that these were perhaps one of the highest reports reported anywhere in literature. It was unfortunately and disturbingly low postpartum screening rates. The third thing, and when we've talked about this in the past, the third thing was that overweight and obesity significantly increased from their pre-pregnancy or their first trimester weights to the postpartum. So overweight and obesity, which was in about 1 of 3 women at the time they became pregnant, was in 70% of the women by the time we evaluated them in the postpartum period. So clearly, gain in weight was something which was contributing. And the mean BMI change was about 4 units at an interval of 2.3 years. This is a massive increase in BMI. And therefore, because of the high numbers and the fact that this happened so soon after delivery, it became that this is an important problem, and we don't have the luxury of waiting 5 years or 10 years, because by 4 years, 50% had already transitioned. Then, of course, when we were sitting and planning what to do next, the criteria changed to the IAD-PSG criteria. And in the Carpenter and Couston defined cohort, 70% of these women were on insulin during pregnancy, because they included women of even a more severe degree of hyperglycemia, which got knocked off with the IAD-PSG criteria, and that anybody with a value of more than 126 in the fasting and 200 in the post-glucose load were considered overt diabetes. So if you use the IAD-PSG criteria, only 20 to 30% of women were typically using insulin, so we were looking at milder hyperglycemia. So we decided to look at this. Again, there are a bunch of representative studies, one prior to us from Delhi, one from Chandigarh, one from Chennai, which showed that as opposed to that nearly 30% diabetes which was being reported, when Carpenter and Couston criteria were being followed, about 10% was approximately the number of women who are transitioning, which didn't mean that things became better. It just meant that we'd removed the women with higher degrees or more severe hyperglycemia from the calculation altogether. And in addition, there was another 20 to 30%. So, but most of these studies had actually been conducted over a very short follow-up period. And so we then planned a study with at least a 1-year postpartum follow-up of women who'd been diagnosed with GDM using the IAD-PSG criteria. And here we found that yes, if you look at dysglycemia put together, there was about, nearly 60% of the women still were dysglycemic in the follow-up period. But the numbers who'd converted to diabetes were smaller, and the bulk was people with prediabetes. In addition, the predictors of dysglycemia were, and this is important, were, as expected, insulin use, diabetes in a first-degree relative, the time since index delivery. The further you were from that, the more likely you were to progress. The older you are, this is much more likely. The higher your BMI, you're much more likely. Of course, features of clinical and biochemical features of insulin resistance. These are all, expected, anticipated, and obvious, but we just documented that in our study. Now, again, the important thing I want to point out is when you compare these data with the HARPO study, which then, resulted in the IAD-PSG criteria, India was not part of that population. At a median follow-up of 11 years, 10% of the women in the HARPO study had developed clinical and biochemical diabetes. We had the same number at 1.6 years of follow-up. So there was a rapidity of transition happening out there, if it was a transition, and it really meant that there was a sense of urgency to intervene. Now, the biggest problem in trying to intervene in a woman who's just had a baby is there are many conflicting commitments. She has to look after the baby, she's continuing to do all her other work, and if she is somebody who is working outside the house, sooner than later, she has to rejoin her work. So, telling them to, you need to do 45 minutes of physical exercise is pie in the sky. It's not going to happen. But you really need to still communicate that. And so the important message from us was that we need to do something, but what's that something? Of course, the other issue was that this was a single center study, and this may be because it was done at the All India Institute of Medical Sciences, where we have often more likely to have women with high-risk pregnancies. This may not be truly representative of the rest of the country. So we then developed an intervention study, which we call LIVING, Lifestyle Intervention in Gestational Diabetes. We were in collaboration with colleagues at the George Institute. This was funded through a Global Alliance for Chronic Disease Mechanism. And essentially, this study was done in 19 South Asian centers. Delighted to see people who were very active and gave us incredible support. I can see Dr. Pathan sitting here. Dr. Mohan, of course, has been a collaborator of long standing. I saw I saw Dr. Sanjay Barada in the morning. I saw Dr. Tushar from KEM. So, and of course, the Vellore team was very much part of this particular study. There were about 10 centers in India, 5 in Sri Lanka, and 4 in Bangladesh. And essentially what we did, this is an open label parallel group pragmatic individual randomized control trial with a blinded primary endpoint adjudication. These are called probe studies. And essentially, this was with keeping implementation and translational research in mind. The idea was to develop an intervention which, if successful, could be taken up by the health system without difficulty and without significant financial implications. And the calculated sample size was about 1,400 women across these 3 countries. And the primary outcome was, can you prevent a change in glycemic category? So if the woman in her post-pregnancy GTT was normoglycemic, can we prevent her from becoming either pre-diabetic or diabetic? If she already had intermediate hyperglycemia, can we prevent her from progressing to the next level of dysglycemia, i.e. diabetes? And essentially we looked at this, that we needed to do a postpartum GTT, and that the lady should not have had diabetes between 3 to 18 months so that we could intervene. This is a sense of so it was a reasonably distributed study across different parts of India. As I mentioned, there were 5 centers in Sri Lanka and 4 centers in Bangladesh. So women with gestational diabetes were diagnosed between the age of 24 and 34 weeks. They then were, so it was a really difficult study. If you imagine a prospective study in which you first went to the woman and said, would you be willing to participate in this study in future? So that was the first level of consent, which most women said happily yes. I mean, because they felt beholden to their treating team, and they said yes. Then you go back to them 6-8 months later and say, maybe invite you for an oral glucose tolerance test, and it goes down to 50% straight away. So, you know, it was a very difficult study. We're used as diabetologists, endocrinologists are used to, you know, recruiting and randomizing within a couple of weeks. Here it was recruitment in pregnancy and randomization 8 or 9 months ago. So it was perhaps the most difficult study I've ever done. So in that GTT, if you did not have diabetes, if you had diabetes, you were excluded. Otherwise, you were randomized, and then you were either in an intervention, which I'll describe shortly, or in a control arm, and then you were followed up every 6 months. So this was a very light touch intervention, because if it was going to be successful, it had to be incorporated into the health system. And it could not add burden, either fiscal or resource or human resource wise in that. And essentially there were post-randomization 3 sessions. Then there were 2 SMS messages every week, followed by a monthly phone call, a 4th session at the end of 6 months, at which time we reviewed the individual, and if they had not suitably lost weight, they were then further subjected to an intervention sessions which were tailored to their specific problem, and the SMSs and the monthly phone calls continued. So it was a year of intervention, and then it was evaluated. So the baseline characteristics was, and this is important for me to point out, because our post hoc analysis showed where we possibly could have done better with the recruitment, that of the women who were selected, 60% or thereabouts had normal glucose tolerance at the time we did the postpartum GTT. Obviously, they became eligible for an intervention, but this has implications, and I'll come back. And the remaining 40% had different levels of intermediate hyperglycemia, whether it's IFG, IGT, or both. So again, it's important here to point out this was within 3 to 18 months. About 10% of women already had diabetes. Now, whether they were women who had continued to have diabetes or converted, we cannot say. But still, that means, you know, interventions have to be done really, really early. And the other point which is important to note is that about 65% of women were either overweight or obese. So again, weight has an important role, and weight therefore becomes an important target for control. Now, the sad part of the story is that we of course ended up recruiting more. This was bang in the middle of COVID, as it so happened. So COVID derailed a lot of things for us. Some of the sessions which had to be face-to-face got converted into virtual sessions. We could not do WhatsApp group sessions because it would impede on the privacy of the woman. So we had to do single sessions. It added to the burden of the staff. We could not expect people to go out and walk because there were lockdowns, and then it was not considered to be safe. So a lot of what we'd hoped to do with forms of intervention didn't really happen. But eventually, though there was some difference between the standard and the intervention arms, it really did not achieve statistical significance. So in terms of the required outcome, it was a negative study. But this is the largest study ever conducted globally. At the time we went into this particular study, 2 other studies had been reported on the clinical trials, clinicaltrials.gov. One was in Brazil, the other in China. They started before us, they still haven't completed. So, you know, to that extent, we feel happy we did this study. It was an incredible testament to all the research staff that despite COVID, they managed to do it. They did home visits for the final outcomes. We arranged for things. It was basically a very labor-intensive study, unfortunately negative, but it showed that, you know, this is what you could have done in real life, but it didn't work. Now, based on this, there has been now a living systematic review and a meta-analysis which has been done. Now, if you use, I'm sorry, it's not coming out very clear, but if you use the 10 studies which have looked at a strategy to prevent progression or conversion, the overall systematic review suggests that lifestyle interventions are really not incredibly successful in doing this. If you, of course, do a slightly dissimilar assessment of only those studies in which a survival analysis was done, there was a marginal benefit which was seen. But clearly it showed that there is equivocal evidence about the efficacy of interventions to reduce using lifestyle interventions And the review actually highlights the need for further studies, including looking at pharmacotherapeutic interventions for preventing this. So we've now just about to embark on a study. We move from living to divine. It's called Drug Intervention for Prevention of Type 2 Diabetes, and this is again a study in women with prior gestational diabetes. I'll come back to the recruitment criteria here a little later, but essentially it's going to be metformin vildagliptin versus a placebo layered over a lifestyle intervention as was done previously. Now, this is the important message which we then got from a post-hoc analysis of the living study. We looked at the risk factors of postpartum diabetes. Again, a study was done because of the cooperation and collaboration of 19 centers across South Asia. And we wanted to really see, could we be a bit more granular in identifying the women who are more likely to progress towards diabetes, and therefore can we focus on them instead of doing it to everybody. So, we used the policy before that any woman with prior GDM is one homogeneous group and they all have an equal risk in progression to type 2 diabetes. Our own data showed that that was a wrong assumption. So we essentially tried to look at the evaluation of progression to diabetes in women who had normal glycemia, impaired fasting glucose, impaired glucose tolerance, or both at the first postpartum visit, all of whom are included in our intervention. Now this is what we really found. I remind you that about 60% of the women in living had normal glucose tolerance in their postpartum OGTT. Look at their incidence rate, it was just 3% annually. So, if such a large part of the women were normal glucose tolerance, it really caused a reduction in the anticipated power of our study. Now go ahead and look at the other two. If you had either impaired fasting glucose or impaired glucose tolerance, it was about 10 or 12%. If somebody had both impaired fasting glucose and impaired glucose tolerance, it was about 30%. So based on this, when we started the protocol for Divine, we said, we will now concentrate on only those women who had GDM in their previous pregnancy and now in their postpartum glucose tolerance test had pre-diabetes. We will now not sort of intervene in those who had normal glucose tolerance because we know that that is perhaps not converting fast and we need to give them advice and need to make them aware, but that may not be the best population to focus our efforts on, and therefore we decided to look into drug intervention. Now the other thing is, it's just, again, a bit of data mining, but we also looked at the incidence of postpartum diabetes based on the type and number of glucose abnormalities on antenatal OGT. So these were the IDPSG GTTs done during the pregnancy, based on which they were diagnosed to have gestational diabetes. So you could have had either single abnormal values, which could be either of abnormal fasting glucose, impaired abnormal 1-hour glucose, or an abnormal 2-hour glucose. If you see, this adds up to about 50% of the women had only a single abnormal GTT value. Another 20% or so had 2 abnormal values, which could be either 0 in 1 hour or 0 in 2 hours, or 1 in 2 hours, and then another 20% had 3 abnormal values. And again, you can see the gradient out there. Those who had a single abnormal value were between 4 and 5% likely to develop postpartum diabetes in the follow-up period which we had, right? The moment you went to 2 abnormal values, it was more like 8 or 10%. But if you had all three abnormal values, you had a 20% odds to develop. And these are important things because this is a conversation you're having with a woman in pregnancy when you're being diagnosed. I realize that the obstetrician at that point in time, and correctly so, are focusing on pregnancy outcomes. But this is some conversation which really needs to be put in at the same point of time. So 1 abnormal value, 4%, 2 abnormal values, 8%, 3 abnormal values, 19%, a very clear gradient which was visible to us. More recently, the International Diabetes Federation came up with a paper which said, do we need to relook at the 1 hour post-glucose? Once upon a time, some of us are old enough that we did 0, 1, and 2 hours. does a 1 hour glucose value add anything to our ability to diagnose? And there was a nice paper which came out in DRCP, I think it was in 22 or 23, I forget which. So we decided to look at the implications of the antenatal 1 hour post-load plasma glucose for postpartum diabetes and cardiometabolic risk assessment. So you can really make out that if you compared women who had, and we use the same cutoff as was used in the IDF paper, which was a 1 hour post-load value of less than 11.6, which is about 200 milligram per deciliter. Those with or those higher than that, you can see there was a clear difference. So what I'm trying to suggest is that I'm not saying we're not recommending shifting, but you can actually get a reasonable sense even at the 1 hour value, and that is going to be higher. Now, in all this period of time, because the IADPSG criteria identifies something which is, as I said, towards the left of the range of hyperglycemia, anybody with a fasting of more than 126 or a post-load of more than 200 were removed from the bucket of gestational diabetes and are called differently by different people. We've preferred to call it as overt diabetes in pregnancy. We just wanted to see, how they performed in the postpartum period. So we have a cohort of women with hyperglycemia in pregnancy in their families. We call it the CHIP-F cohort, which has women, a bulk of them have gestational diabetes as diagnosed by the IADPSG criteria. We have about 100 women who had values which are consistent with the diagnosis of overt diabetes in pregnancy. We had 100 women who had pre-existing diabetes, and then of course we have women with normal glycemia, and these were classified using this. We then went on to look for cardiometabolic outcomes in women in all these 4 categories. So if you look at the outcome for diabetes, obviously we remove the women with pre-existing diabetes because they already had diabetes, but you can see again a very clear gradient. Those who were normal glycemic, 2%, those with gestational diabetes, 15%, those with the word diabetes in pregnancy, 70%. So I can, again, so I'm making this for 2 reasons. If you have values which are that high, there is a 70% chance that that woman is going to progress to diabetes in the 2 or 3 or 4 years of follow-up which we had during this particular study. It also tells me that everybody with, as somebody would argue that how do you know the overt diabetes in pregnancy were not really pre-existing diabetes because you had no data? And that's a fair question. But the fact that 30% did not have diabetes on reassessment tells us that they did not have pre-existing diabetes, because otherwise they would have again shown up with diabetes at this assessment. So clearly a more severe hyperglycemia in pregnancy is linked to a more likely. This is logical, this is expected, but these are really the first set of data which are clearly demonstrating that. So again, just to capture that, overall prevalence of diabetes in women with a diagnosis of overt diabetes in pregnancy was 70%. If they were diagnosed in the first trimester, it was 93%. Among women diagnosed based on an antenatal HbA1c within 15 weeks, it was 95%. And among women diagnosed based on a 2-hour plasma glucose tolerance, it is about 60%. So, clearly, and this, of course, you can always argue that the first trimester were really women with pre-existing diabetes, so it's not something. So risk of diabetes, future diabetes, in a woman diagnosed to have overt diabetes during pregnancy was 15-fold higher than women diagnosed with gestational diabetes using the IADPSG criteria. So again, we need to tease these things out. The title of this conference is Navigating the Heterogeneity of Diabetes. And what I'm trying to bring out is that we perhaps have very conveniently put things in one bucket, and I'm not saying that these are not one bucket, but an element of granularity needs to be reviewed so that we can address them differentially. The other thing is, and this is not in any way trying to say that one set of criteria is better or not, but I think it's important for us to understand that if certain criteria end up missing the diagnosis of GDM compared to, let's take the IADPSG criteria as a gold standard for this point in time, could it have implications for the mother and child, because they will not be subjected to any intervention. If you don't make a diagnosis of a disease, you don't treat the disease, right? So we actually compared, looked at those who are testing positive for gestational diabetes by the IAD-PSD criteria, but were negative by several other criteria which are used in different parts of the world, including DIPSI, which is used in India, the UK NICE, and the Canadian Diabetes Association. And you can see that DIPSI ended up missing about 60% of women who were being diagnosed by IAD-PSD. We'll come to the implications of that in a second. The UK NICE criteria, if we'd applied it to our population, were missing 40%, and the Canadian Diabetes Association was missing 1 in about every 4. So one is that there are women who these women will no longer be subjected to an intervention. But that's not really enough. We also need to demonstrate that, by missing these women out, are we actually preventing them from getting a treatment which would have given a benefit? So we've now embarked on a largish study. This study is, it's a bit of a mouthful, I'm going to try and read it. Evaluation of maternal and fetal outcomes in women diagnosed with either gestational diabetes or normal glycemia using the IAD-PSD criteria among women who are diagnosed with normal glycemia by the DIPSI criteria. The DIPSI criteria, by and large, perhaps much more commonly used in the country. So the question being asked was, let's say you have 100 women who are subjected to the GTT and defined by the DIPSI criteria. Let's say 50% of those are found to be normal glycemic. I'm just giving you random numbers. If you then subject them to another GTT using the IAD-PSD criteria, will we identify more women, right? What we are doing out here is, given the fact that the DIPSI criteria, the primary criteria used by most people, the second GTT, which is being analyzed using the IAD-PSD criteria, is kept blinded and not used for an intervention. Therefore, if you were diagnosed as normal glycemic by the DIPSI criteria, you continued as normal glycemic, and we will then evaluate later whether by missing these women out, we ended up with any differences in maternal or fetal outcomes. Obviously, if the IAD-PSD criteria resulted in overt diabetes, they were censored at that point in time and treatment initiated. So the plan was for 17,000 pregnancies. We have redone, fortunately, our statistical, we decided that after doing half of them, we'll do a reassessment. We've now been told we can get away with, if I can use the word, with 12,000 pregnancies. So we've recruited 7,000 and a bit till now. Hopefully, a couple of years or so, we will be able to give you some answers. And so based on this work again, and there has been a risk prediction model for postpartum onset of type 2 diabetes, which is now being developed, and nobody can read this, including me. But essentially, 2 models were created. One was an antenatal model, which had 7 variables, which included antenatal fasting glucose, antenatal 2-hour glucose, history of recurrent GDM, insulin treatment in pregnancy, parity, history of an irregular menstrual cycle, and family history of diabetes. This was a model which could be applied in the beginning. And then there's a postnatal model which includes antenatal GTT, because we had the value already, postnatal fasting, postnatal 2-hour, and postnatal body mass index, or BMIs. And both these models have about a 75 to 85% ability. The postnatal model obviously works better, though it has fewer variables, but you're that much better off in predicting that. So with the living study, we managed to do 2 or 3 things which we are really happy. We didn't achieve what we set out to do, but we've now identified the risk factors better. We have contributed to a very large systematic review in which the bulk of the people come from living, and now we also contributed towards a risk prediction model, and hopefully these models will get refined with passage of time. As I said, the sensitivity was wasn't 75 and 85, it was 70 and 80. So let me end this by saying it's been a very important area of work for us, and we started that about. So this started primarily with a DM dissertation for one of our endocrine fellows, who has subsequently joined us on the faculty and has decided to take on this part entirely as his life's ambition. So now he does the work and I do the presentations, which I thought was a fair distribution of work, considering that I started him off. So The risk of type 2 diabetes in women with prior gestational diabetes is nearly 10 times higher. But if you take the bucket which has got overt diabetes, it's even higher. The other thing, the conversion rates are higher, and I didn't show you the data, higher than most ethnicities. Even more importantly, the window of opportunity we have is small because the conversion's iffy. And as I said very right in the beginning, the word conversion may or may not be acceptable to the audience, but just for the sake of explaining what I'm saying, the conversions are happening at a very short, small period of time. The other part, which I didn't talk about at all, was there were multiple cardiometabolic abnormalities which seem to be linked. So both in terms of blood pressure, lipids, and other factors. The risk of incident diabetes in women with prior GDM categorized by postpartum GTD levels clearly is, if you have both IFG and IGT, that's more than either one of the two, which is more than NGT. So focusing on NGT, I'm not saying we shouldn't do it, but possibly if you've got limited resources and limited effort, you need to do it on women who had prior GDM and then went on to also have intermediate glycemia, hyperglycemia in the postpartum. And the risk of incident diabetes increases with the number of abnormal results in the postpartum GTD. Again, expected, but we've clearly demonstrated it. So we now need a strategy. Obviously, our light touch intervention, vitiated by COVID, and perhaps underpowered because of the large bulk of women having normal glucose tolerance, may or may not be adequate. Well, it wasn't adequate there. If we can do another study, nobody's going to fund a second study without COVID, but there you are. Early and intensive intervention is what's required. And one of the areas we're looking at is, of course, the family as a unit for intervention, because it's easier when you do this with the whole family doing certain things as opposed to the woman expected to do certain things while everybody else in the family doing things their sweet, merry ways. And of course, we need to possibly look at an intervention study with pharmacotherapy, which we are hoping to start in the next month or so. So this has been really a lot of people involved. I mean, it's, I won't count the names out, but this has just been a whole bunch of people within the Department of Endocrinology at AIIMS, the Department of Obstetrics and Gynecology at AIIMS. We have collaborators from Australia who helped out with the original work, and we still work with the George Institute. I worked with them for about 25 years now. Obviously, lead investigators. I haven't listed the site investigators out here from Sri Lanka and Bangladesh, and other colleagues who've worked. And a lot of money has come from a lot of different places, including the Indian Council of Medical Research, International Diabetes Federation, which kicked off this whole thing with a bridge grant, a translational grant, AIIMS intramural grant, the Endocrine Society of India, and pharmaceutical support. So I can put on record the US Vitamins and Lupin also gave us money for this. So there's a whole bunch of people who gave us. I'll stop here and thank you so much, not only for listening to me, but once again for inviting me to speak in front of you. Thank you.
May I request everyone to rise and give a standing ovation for Professor Tandon.
Well, it remains for me just to thank you. You will all agree with me that we have heard an exciting lecture.